In today's rapid update, we'll be going over the Society for Immunotherapy of Cancer, also known as the SITC's newest update on immunotherapy for the treatment of gastrointestinal cancer. These guidelines were originally published in 2023, but underwent a focus update on May 28, 2025. In today's video, we'll just be going over key changes, so to get the full recommendations, including FDA approvals for new or expanded indications, make sure to check it out on guidelinecentral.com. We'll start off with the tissue-agnostic indications for immunotherapy in the treatment of GI cancer, specifically in the DNA polymerase epsilon and delta, also known as POLE or POLD1 section. For all patients with GI cancer, MSI or MMR status and TMB testing should be performed on tumor tissue in a CLIA certified lab. MSI status and TMB may be obtained by NGS. MSI can also be determined by PCR. MMR status may be obtained by IHC. Next, we'll take a look at new and updated recommendations that were added in the esophageal, gastroesophageal, junction, and gastric cancer section. For patients with gastric or GEJ adenocarcinoma, CLDN 18.2 testing should be performed using a validated antibody. For patients with resectable gastric or GEJ adenocarcinoma, that is dMMR or MSIH preoperative ICIs should be considered in consultation with a multidisciplinary team. For patients with unresectable or metastatic ESCC, following prior systemic chemotherapy that did not include a PD-L1 inhibitor, tislelizumab is recommended. For patients with untreated, locally advanced, unresectable, or metastatic HER2 negative PD-L1 greater than or equal to 1 gastric or GEJ adenocarcinoma, nivolumab, pembrolizumab, or tislelizumab with fluoropyrimidine and platinum-containing chemotherapy is recommended. For patients with locally advanced, unresectable, or metastatic HER2 negative, CLDN 18.2 positive gastric or GEJ adenocarcinoma, zolbetuximab in combination with fluoropyrimidine and platinum-containing chemotherapy is recommended. There are no comparative data regarding the efficacy of zolbetuximab plus chemotherapy versus an ICI plus chemotherapy where both zolbetuximab and ICI therapy are indicated. For patients with untreated PD-L1 CPS greater than or equal to 1, HER2 positive advanced esophagastric adenocarcinoma, chemotherapy plus trastuzumab plus pembrolizumab is recommended. Now on to the biliary tract cancer section where we find two updated recommendations. For patients with untreated advanced BTC, treatment with combination gemcitabine and cisplatin with durvalumab or pembrolizumab is recommended unless a contraindication to immunotherapy exists. For patients with treatment refractory immunotherapy naive advanced MSS PMMR BTC, treatment with a clinical trial is preferred, but the following are considered suitable if a trial is not available: lenvatinib plus pembrolizumab or nivolumab, nivolumab plus ipilimumab, or nivolumab or pembrolizumab. Finally, we'll cover two additional updated recommendations for colorectal and anal cancers. For patients with untreated metastatic MSIH, dMMR, CRC, pembrolizumab monotherapy or nivolumab plus ipilimumab are treatment options. And the final recommendation for patients with MSIH, dMMR resectable rectal cancer, phase 2 data from a single center study of neoadjuvant ICI therapy suggests remarkable activity. ICI as neoadjuvant or definitive therapy with non-operative management in consultation with a multidisciplinary team can be considered, but clinical trial participation is preferred. And there you have it. Make sure to check out the full guideline from the Society for Immunotherapy of Cancer and other related clinical decision support tools at guidelinecentral.com.